Hello and welcome everyone. My name is Emily Bell and I'm the Associate Director of the National Colorectal Cancer Roundtable. We've had a lot of interest in this topic and appreciate everyone's time in making an effort to join us today. The purpose of today's webinar is to provide guidance on implementing quality colorectal cancer screening programs using the Fecal Immunochemical Test, or FIT. FIT-based programs play a key role in the effort to get to 80% screened for colorectal cancer by 2018, but many of us have questions about how to select and implement the strategies that will lead to a successful program. During the webinar, we will hear from Dr. Dorado Brooks, Managing Director, Cancer Control Intervention of the American Cancer Society, and Dr. Gloria Coronado, Mitch Greenlick Endowed Senior Investigator in Health Disparities Research at the Kaiser Permanente Center for Health Research. Dr. Brooks and Dr. Coronado will review the rationale for FIT-based testing, share strategies for implementing quality FIT-based programs, and address possible solutions to common barriers to implementing these programs. I'd like to share a few housekeeping items before we get started. We are recording today's webinar. The replay and speaker slides will be shared with all of you within a few days. Please feel free to share with your colleagues that were not able to join us today. Also, because of the large number of participants, all participants are muted on today's webinar. Having said that, we will want to make sure you get what you need out of the webinar. So we encourage you to ask questions by submitting them to the webinar Q&A function. We will have time for questions after the presentation, and we'll answer as many as we can. And we'll also be emailing around any responses to any questions we don't have time to get to. You can also email us specific questions afterwards. And finally, we are always trying to improve our webinars, so we're asking for your help in evaluating the webinar. You will be receiving an email with a survey link. Please help us out with this by taking a few minutes to provide feedback. We take this advice very seriously and are always trying to improve. So with that, I'm pleased to turn the webinar over to Dr. Dorado Brooks, who will begin with providing an overview of the evidence base for screening with FIT. So let me pass the baton to you, Dr. Brooks, and we will get started.
All right. Thank you, Emily. And thanks to everybody for joining the call. We've got a great deal of information to cover, and we want to be sure to leave some time at the end for questions. So I'm going to be zooming through quite a bit of information here. Now, as many of you are likely aware, the U.S. Preventive Services Task Force just last week, I believe, or 2 weeks ago, updated their recommendations for colorectal cancer screening. Previously, they focused on colonoscopy, stool testing, fecal occult blood testing, and flexible sigmoidoscopy. As you can see, their menu has expanded quite significantly since that time. And actually, these guidelines really mirror those that the ACS has promoted since 2008. With regard to stool testing, the major change was the addition of stool DNA testing, what they call FIT DNA, which I will be talking about briefly at the end of my remarks. It's important to remember, however, that stool testing of all types, be it fecal occult blood testing or the FIT DNA testing, is at present only recommended for average risk population. So these remarks are really focused around screening your average risk population. In most practices, that's 80% or more of your patients. So it's relevant to the bulk of your patients. So when we talk about fecal occult blood testing, there are two types. The first being Guaiac tests. Guaiac tests have been around forever, 50 years or more, and are by far the most commonly used still in the U.S. There's solid evidence from 3 randomized controlled trials that we can decrease death from colorectal cancer using a Guaiac-based program. And one of those studies actually published a 30-year follow-up study about 3 years ago that demonstrated that 30 years after being involved in a Guaiac screening program, individuals were still about 30% less likely to have a colorectal cancer death. All Guaiac tests require collecting specimens from 3 separate bowel movements. These tests are nonspecific, so bleeding from any source, even a rare steak meal, can potentially cause a positive Guaiac test, and certainly bleeding from elsewhere in the upper GI tract, or even someone has a heavy nosebleed and swallows some of that blood, all of that can cause a positive Guaiac test. What many people do not appreciate is the improved sensitivity of new Guaiac tests, specifically Hemoccult Sensa, compared to the cancer sensitivity for Hemoccult 2, which in most studies is 20% or less for cancer, hemoccult sensa in most studies is 60% or so sensitive for cancer. So we're talking about strikingly higher levels of sensitivity, to the point that both the American Cancer Society and the Preventive Services Task Force guidelines specifically say if you're going to use Guaiac testing, it should be high sensitivity Guaiac tests, and really hemoccult sensa is the only high sensitivity test that has performance data in the medical literature. Now, the other approach to looking for hidden blood is the Fecal Immunochemical test, sometimes referred to as an IFOB, but most commonly referred to as a FIT test. These tests have some advantages over Guaiac. One, they are specific for human blood, so that rare steak that I mentioned will not cause a positive FIT test. In addition, they're specific for lower GI bleeding. FIT tests look for the globin portion of the hemoglobin molecule, and globin is very sensitive to upper GI enzymes. So if someone has bleeding from the upper GI tract or the nosebleed that I mentioned, that blood is going to be changed in such a way by the time it exits the body that it would no longer be picked up by a FIT test. So in order for a FIT test to be positive, in most instances you're talking about bleeding from the lower GI tract, or it would have to be very rapid and voluminous bleeding from the upper GI tract so that it did not get changed or denatured. The results are not influenced by any foods or medications that we're aware of, unlike Guaiac tests where there is a long list of foods and medications that can cause both false positive and false negative Guaiacs. For many of the FIT tests on the market, only 1 or 2 specimens is required for a complete test, as opposed to 3 specimens for all Guaiac tests. These tests are much more sensitive than hemoccult 2, and actually in most studies are more sensitive than for cancer than even hemoccult sensa. Sensitivity for FIT in most studies is 70% or greater cancer sensitivity. And finally, while these tests do cost more than Guaiac tests, they also are reimbursed at a higher rate. Consequently, if you're able to get a good return rate on your kits, then you can actually not lose money switching over to FIT. And in some instances, clinics actually find that they can increase their income slightly. Now, there are a number of different issues that are causing barriers to the use or broader use of stool testing. While most primary care clinicians understand that these tests are out there and they do use them to a degree, in many settings their effectiveness is questioned. And much of that is because they do not appreciate the difference in sensitivity between older tests like hemoccult 2 and these newer tests, hemoccult sensa and the FITs. And there is still a very, very strong bias toward colonoscopy, and colonoscopy is frequently referred to in primary care settings as a gold standard. And unfortunately, even in settings where clinicians recognize that their patients may not have access to colonoscopy, oftentimes colonoscopy is the only test that is being recommended for them. So if the patients either can't or won't have a colonoscopy, they don't get screened. And it's been shown in many, many settings that this sort of sole focus on colonoscopy leads to lower screening rates. The other issue that we've come to recognize is very important that many primary care clinicians don't appreciate is patient preferences are often strikingly different than those of their clinicians. And this is illustrated by this study. I think there were about 1,200 patients in a safety net facility, all of whom were due colorectal cancer screening. And the patients were put into 3 groups. The first group was told, go get a colonoscopy. No cost, just get this colonoscopy done. Second group was told, take these kits home and collect stool specimens and return them. And the third group was told, you can have a colonoscopy or you can have a stool test. You choose. What they found was at the end of the study period, only 38% of those patients who were only offered colonoscopy completed their screening. Less than 4 out of 10 got screened. On the other hand, patients who were only offered stool testing, 67%, 2/3 of those individuals got screened. And people who were offered either the choice of stool or colonoscopy, 2/3 of those folks got screened. And notice that more people in that group chose stool testing. There have been a number of other studies that have looked at this issue, And in each instance, they found that anywhere from a third to half of patients, if given a choice between stool testing and colonoscopy, will choose stool testing. Yet, in most primary care settings, patients are not given a choice. In many instances, they have no idea that there are other options for screening, as a matter of fact. Part of this, again, comes back to the fact that primary care clinicians are concerned about the accuracy of stool testing because most still perceive stool testing as the Hemocult 2 20% sensitivity for cancer. Well, this meta-analysis looked at modern stool testing with a focus on FITs. A number of these FITs actually are either no longer marketed in the U.S. or never were, but across the board, looking at, I believe, 12 or 14 different brands of FIT, they found that in general, the sensitivity for cancer was 70% or greater for the vast majority of these. And the specificity for cancer was very high, or for abnormalities, at least, was very high, with over 90% specificity. So these tests are strikingly different than the older forms of stool testing, but many primary care clinicians don't appreciate this. Now, with regard to the recent U.S. Preventive Services Task Force evidence review, they also did a modeling study looking at the potential outcomes with different approaches to colorectal cancer screening on a population-wide level. So looking just at the blue bars here at the bottom, they estimated the benefit from colorectal cancer screening, the number of deaths averted from colorectal cancer per 1,000 individuals screened. And on the far right is COL every 10 years. That's colonoscopy once every 10 years. They estimate that 24 colorectal cancer deaths would be averted for every 1,000 individuals screened with colonoscopy. From a societal standpoint, that's a really good investment. That's a good return on the investment. 24 lives saved. Now, if you look on the far left, FIT 1Y or GFOBT 1Y, that's high sensitivity Guaiac testing or fecal immunochemical testing, you can see they estimated 22 deaths averted for every 1,000 individuals screened. Now, is colonoscopy better? Yes. Is colonoscopy strikingly better? No. The overall number of lives saved is very similar between those two strategies. Very similar. And again, this is information that many primary care clinicians don't appreciate. In addition, you have to recommend that, or you have to recognize that screening 1,000 individuals with colonoscopy is very different than screening 1,000 individuals with FIT or high sensitivity Guaiac testing. So there are a number of advantages to using stool test over colonoscopy. One, they're strikingly less expensive. So in most settings, even with very resource-limited patients and highly uninsured patients, stool testing is a viable option. There's no bowel preparation required. In research that we've done looking at barriers from the patient perspective, a lot of patients are very resistant to the colonoscopy prep. These tests are done in privacy at home. That's something else that we found is very important for patients. A lot of patients are embarrassed at the idea of colonoscopy or how they perceive colonoscopy to be performed. So when they're made aware that there are tests that they can do at home, that is very appealing for them. There's no need to take time off work. You don't need assistance getting to or from the visit as you do with colonoscopy. These tests are non-invasive, really no pain and no risk involved with the stool test itself. And they limit the need for colonoscopy very significantly. So again, when we talk about doing 1,000 colonoscopies, that's 1,000 colonoscopies that has to be done. So let's look at this slide, which is actually courtesy of Dr. Coronado, who you'll be hearing from later. But if you're going to screen 1,000 patients with colonoscopy as your primary or sole approach, number one, you're going to get a number of patients who don't show up. But you'll get a number of folks who do undergo colonoscopy, but you're going to find very few cancers in that group. It's estimated that 1 in 400 to 1 in 1,000 screening colonoscopies will find cancer. So very few cancers. On the other hand, if you do FIT testing, 2,000 patients, you're screening a much larger number of folks to start with. You're going to have a relatively small number of those folks. In most studies, less than 10% of those people are going to have a positive FIT test. So you're going to do many, many fewer colonoscopies, but those colonoscopies are going to have a much higher yield. You're going to end up finding cancer in about 1 out of every 20 colonoscopies instead of 1 out of every 400 to 500. So you do many fewer colonoscopies, but you actually find many more cancers taking this approach. Now, it's important that you keep in mind that we're talking about stool testing done in a high-quality fashion. And there are a number of important quality features for stool testing. One, you've got to be using the high-sensitivity test, either Hemocult Sensa or an FOBT. Hemocult 2 and other generic versions of Hemocult are, there's very little, or in many instances, no performance data on those tests, and their ability to detect cancer is strikingly lower, and therefore you're not going to get these same positive outcomes. These tests have to be repeated every year. Even if you have 70% sensitivity for cancer at one-time testing, that means you're going to miss 30% of cancers that may be present, and you're going to miss a larger number of polyps. So you need to be repeating the test every year. So either you find the polyp before it transforms to cancer, or you find cancer when it's still in its earliest stages, when our treatments can be most effective. Every positive test has to be followed with colonoscopy. I hear over and over again from patients who are diagnosed with colorectal cancer about having a positive stool test, and their doctor assumed it was hemorrhoids and told them to come back next year. Every positive stool test is cancer until proven otherwise. Therefore, colonoscopy has to be done on all of these patients. There are a number of throw-in-the-bowl brands of toilet testing, of stool testing, where you get a little Guaiac impregnated paper and drop it in the toilet bowl after a BM. Those tests have very little evidence supporting them, and the evidence that's there shows that they are, at best, as good as Hemocult 2 and other versions of stool testing that are no longer recommended for screening. So please tell your patients these tests are not effective approaches to colorectal screening. And then finally, the digital rectal exam. Many clinicians say, well, I give these kits out to my patients and they just don't bring them back, so I'm just going to do a rectal exam and I'll smear whatever it is I find on that Guaiac card, or I'll stir it around in a little while, and boom, I've screened my patient. You have not screened your patient. Digital rectal exam stool specimens are not an adequate approach to colorectal screening. The one large study that looked at this using Guaiac-based testing, over 2,000 patients, all of whom were scheduled for screening colonoscopy, prior to the colonoscopy had a digital rectal exam sample collected, went for their colonoscopy, and then they compared the findings. There were 21 cancers found in those 2,100 patients. Of those, only 2 of those patients with cancer had a positive digital rectal exam specimen, positive for blood. Only 2. So 19 of 21 patients with cancer would have been missed if that digital exam were the only tests that were done for them. Any test that misses 19 of 21 of the target lesion is not an appropriate test. So if you remember nothing else from today's talk, the digital rectal exam is not an appropriate screening method for colorectal cancer. So if that's happening in your practice, you or your colleagues, you need to stop because you're providing inadequate care to your patients. Now, there are some other quality issues specific to fecal immunochemical testing, and in particular, the fact that not all fits are created equally. After the American Cancer Society and the Preventive Services Task Force included fecal immunochemical testing in their list of recommendations back in the mid-2000s, there was a rather tremendous proliferation in the number of FITs that began applying to the FDA to be utilized in the U.S. And unfortunately, the current FDA criteria for getting your stool test into the market is not, it does not require evidence that these tests find cancer or polyps. All they have to do is demonstrate that they can find blood. And consequently, many of the FITs that have entered the marketplace over the last 10 years or so have done so simply by comparing themselves to Hemocult 2. So they prove they're as good as Hemocult 2, which is no longer recommended for colorectal cancer screening, but that gets them into the marketplace. A recent study that it has not yet been published, but hopefully will in the near future, found that there have been a total of 56 fecal immunochemical tests that have been approved for use in the U.S. By the FDA, and of those, there are 23 that are still marketed. But only a handful of those tests actually have data demonstrating their ability to find cancer or polyps. In addition, some of these tests are marketed as requiring only a single sample in order to have an adequate test, but they don't have good data showing what their performance is for a single sample versus multiple samples. So we have actually been working with the FDA to try to tighten up this criteria, and reportedly they'll be releasing some new guidance in the near future. Meanwhile, these are the tests that we've been able to determine have some data in the medical literature that actually demonstrates their ability to detect cancer or polyps. As you can see, I said there's 23 marketed right now. There may be one or two other tests. We're still in the process of completing our literature review to look at that issue, but there are not many. So what I would say is if you're using an FIT that is not on this list, you need to, at a minimum, ask your representative, whoever is selling these kits to you, to provide you with their performance data, not the data showing they can detect blood, but what data do they have showing their ability to find cancer or polyps. If they're not able to provide you with anything demonstrating that, then I'd encourage you to look at switching over potentially to one of these other tests. You want to use tests that actually are going to perform in a way that those models that showed lives saved would be appropriate and accurate. A lot of this information is summarized in this one-page front and back document about high-quality stool testing. It talks about the difference between older versions of Hemocult and current high-quality, high-sensitivity stool testing. And it also talks about how to implement a high-quality stool testing program in your practice. All this information, one page, front and back. You can find it on the American Cancer Society website or the NCCRT website. Now, I'm going to switch gears, and in just a couple of minutes, as I mentioned, the new U.S. Preventive Services Task Force guidelines, in addition to recommending high-sensitivity stool testing for occult blood, also includes stool DNA testing, or FIT DNA. Stool DNA tests operate differently, whereas Guaiac and fecal immunochemical tests specifically look for blood, therefore you have to have a bleeding lesion. Tests that look for stool DNA don't require any blood to be present. If as stool is passing through the colon, it scrapes off a few cells off the colon wall, and therefore there are cells from the colon wall that are included in any stool specimen. The folks who developed these tests have figured out how to take that specimen, that bowel movement, how to spin it down, separate out those colon cells, and then break those colon cells down and look at the DNA. And they look for DNA mutations that are associated with both polyps and cancer. There's currently only one such test in the market in the U.S., and that test is called Cologuard. And Cologuard actually combines looking for these DNA markers that are associated with cancer and polyps, and combines that with a FIT test. So this is really a twofer. It's a stool DNA and a FIT test combined. There are now two studies looking at colonoscopy supported data looking at these tests. This is the largest, and this is the test that got Cologuard approval by the FDA to be marketed in the U.S. And in this study, looking at over 1,000 individuals, again, all of them were going through screening colonoscopy, they demonstrated that their multi-target DNA test, that is combining the stool DNA detection with FIT, they had 92.3% sensitivity for colorectal cancer at all stages. If you look, however, here on the right, the FIT portion alone had 73, almost 74% sensitivity for cancer. So you got a boost from 74% up to about 93, 92% by adding in the DNA component. But this again demonstrates that FIT alone is a pretty sensitive test for colorectal cancer. Now the green circle here shows the polyp sensitivity, and particularly for what they call advanced precancerous lesions. Those are the kinds of polyps that have a higher likelihood of progressing to cancer. As you can see, for the stool DNA plus FIT component, 42.4% sensitivity for these high-risk lesions versus about 24% sensitivity with the FIT component alone. So again, a significant boost in polyp sensitivity as well. So Cologuard is now, it's been actually approved for use in the U.S. for about 2 years by the FDA, and CMS, Centers for Medicare and Medicaid Services, actually began paying for this about a year ago in advance of the Preventive Services Task Force guideline. But now the task force has also added it as a reasonable approach to colorectal cancer screening. So it's a good test, but there are some limitations. One, it's recommended by the manufacturer to be repeated every 3 years, and Medicare will pay for it up to every 3 years as a screening test. But the evidence supporting that 3-year interval is relatively limited, so the company is doing more research to try to define what the appropriate interval is. Medicare does cover it for individuals between 50 and 85 who are at average risk. Again, this test only for average risk individuals. Private insurance has been very limited, but with the Preventive Services Task Force including it in their latest update, that may change. Like every other stool test, a positive Cologuard has to be followed with colonoscopy. And unfortunately, there are some instances where the test is clearly positive, but colonoscopy, nothing is found. So exactly how to manage those patients is something else that the company is trying to determine and provide some guidance on. And in addition, it's important to keep in mind that the Affordable Care Act requires that patients, if a test has a or B recommendation from the U.S. Preventive Services Task Force, then patients should have no copay or deductible for utilizing that test. But if a patient has Cologuard and uses that as their primary screening approach, then they've used up their Medicare benefit for that year. And therefore, if they end up with a positive Cologuard test, they will have out-of-pocket costs for the colonoscopy that follows that test. All right, I am going to skip over my last couple of slides, and I'm going to turn this over to Dr. Coronado so we can make sure we have plenty of time for conversation.
Wonderful. Thank you so much, and thanks for providing such a comprehensive background on colorectal cancer screening and the recommendations for testing. I'm going to focus on strategies for improving colorectal cancer screening in primary care practices and talk specifically about a study that we have that's ongoing involving 26 federally qualified health center clinics in Oregon and California, and it's called Stop CRC. So the key talking points I'd like to make are that direct mail programs can improve rates of colorectal cancer screening. I want to discuss the design and some of the preliminary findings from Stop CRC. And then I'd like to talk about some of the ways that our clinics have adapted the program to meet their specific context, and also talk about ways that clinics can really assure that they're delivering a high-quality, fit-based program. So by way of background, there's been a variety of approaches used to raise rates of colorectal cancer screening, and these data are based on a systematic review that was conducted by Melinda Davis at OHSU, showing that the strongest evidence or the strongest strategy, the strategy that has the strongest evidence is the direct mail program, and this is limited to studies that focused on vulnerable and rural populations. And so 9 studies showed strong evidence for a direct mail program, 2 studies showed strong evidence for a flu-fit program, and then all the rest of the strategies that were tried, which included improving clinical processes, delivering patient navigation, or providing education to patients in various settings, were met with either moderate, low, or insufficient level of evidence. And so you can see a pretty strong endorsement for a direct mailed approach. So in terms of STOP CRC, we are a 5-year NIH-funded study that's based in Oregon, Portland, Oregon. During phase 1, we developed a collaborative learning environment that brought together an advisory board and a group of EMR site specialists from all of our participating sites. We designed some electronic health record tools to identify patients who were due for colorectal cancer screening and due for each of the steps of our intervention. And then in phase 2, we've delivered the intervention to our participating sites, focusing initially on our intervention sites. We've refined our intervention using the Plan, Do, Study, Act approach, as well as refined our electronic health record tools, and now we're in the stage of spreading and sustaining our intervention both to our usual care clinics as well as more broadly to other sites across the country. So in terms of our intervention specifically, we are a stepwise intervention that includes 3 primary components. The first is a mailed introductory letter, the second is a mailed fit test, and the third is a mailed reminder postcard. And at each of these steps in the intervention, patients are excluded if they have an invalid address, if they report that they've been previously screened and that information is not in their electronic health record, or if they immediately complete colorectal cancer screening and they no longer need any further reminders. We've also incorporated codes that allow us to exclude patients who have a FIT test order in the prior 6 months or have a recent referral to colonoscopy. Our assumption there is that those patients are in the process of getting screened and don't need an additional FIT test sent to their home. And then, as I mentioned previously, we also worked with all of our sites to improve their process using the Plan, Do, Study, Act approach. So this map gives you a feel for where our clinics are located. There's several that are located in the Portland metropolitan area, but we also have clinics in Eastern Oregon as well as in Southern Oregon. And then some of our clinics are in northern part of California as well. And then we also participate with Seymour Community Health Center, which is a 30-clinic federally qualified health center in Western Washington. And we work with 4 of their clinics to test out multiple reminders to a direct mailed approach. So let's talk a little bit about the findings from STOP CRC so far. So in our pilot, we worked with Virginia Garcia, which is a federally qualified health center in the Portland metropolitan area that serves primarily the Latino population. And so we worked with one of their clinics to deliver what we called the automated intervention that included the mailed letter, the mailed fit kit, and a reminder postcard. And in that clinic, we found that about 40% of the patients returned their fit test. In another clinic, we delivered what we called the Auto Plus intervention, which included those same 3 components of the mailed letter, fit kit, and postcard. And then clinic staff called the patients who still hadn't completed their fit test even after receiving those 3 components. And in that clinic, we found a very similar response rate, around 40%. When we compared the response in these clinics to another clinic that we considered usual care, we found that the fit testing rate in that clinic over the 6-month period was only 1%. And so the difference between the rate we found in our intervention sites compared to usual care was 38%. There were 7 patients that were found to have a positive FIT test result, and all but 1 of those patients went on to obtain a colonoscopy as follow-up. As we worked with our clinic to roll out that intervention to the remaining patients in those 2 pilot clinics, what we found was some data that was very encouraging, and that is that Spanish speakers actually had a higher return rate than English speakers. And this was encouraging because we know that both in the state of Oregon as well as nationally, that Hispanics have a much lower rate of colorectal cancer screening than the general population. In fact, data from the Behavioral Risk Factor Surveillance System for the state of Oregon show that Hispanics only 21% of Hispanics are up to date with colorectal cancer screening, and that compares to about 66% for the general population in our state. Part of the reason that Hispanics may have had a higher return rate is that we developed some wordless instructions for completing the FIT test, and this was really based on some advice we got from our project officer, and really responded to the fact that in many of these clinics there are so many languages spoken that it can be really difficult to develop enough written instructions to meet the needs of patients, and it's actually quite challenging to get the right language and materials to the patients who speak that language. So we were really encouraged with these findings, but then we worked with the clinic some more to find out how many of the patients who had a positive FIT test result went on to get colonoscopy. And this is where our data was a little more discouraging, because what we found is that of the 56 patients who had a positive FIT test result, 32 of them went on to get a colonoscopy within 18 months, but there was a big difference in the rate that got the colonoscopy when we compared the non-Hispanics to the Hispanics in our sample. And then when we looked at those that had received a colonoscopy within 60 days of their positive FIT test, we found an even greater difference between our two groups, the non-Hispanic whites and the Hispanics. So this is what we found is to be really where the health disparity exists. It's really in that follow-up colonoscopy. And so the point here is that when you start with FIT testing, you really need to think of colorectal cancer screening as a two-step screening process that begins with a fecal test but ends with a colonoscopy. And both of the steps in the process are vitally important. And what we see is that even though we can get a lot of underserved groups screened with fecal testing, we need to make sure that they also get the follow-up colonoscopy. So I want to talk about two specific examples of some of the PDSA cycles that were completed by our sites. And as background, as Dorado said, there's a lot of variation in the performance characteristics of FIT tests that are being used. This is a sample of the types of FIT tests that are used in Oregon based on information that we've collected across the state. And this is some of the reported performance characteristics. And what I've included on this table are the % positive test results as well as the sensitivity. And you see that in general these numbers look pretty good, with most of the tests having a positivity rate under 10%, and most of the tests having a sensitivity in the over 80%, with the exception of HemoSure. So in general, there's pretty good test performance characteristics, but I would echo Dorado's statement that it's important to know the performance of the FIT test that your site is using. So in contrast to what's been published, when we look at the FIT test positivity rates among the federally qualified health centers that are participating in STOP CRC, we see a different story. And I want to talk a little bit about this because FIT test D is the OC micro test, which we see here has some really good performance characteristics. We know that in the Kaiser system, which has had a mail-out program for years and years, that their positivity rate is about 8%. And we see very similar positivity rate across the 3 federally qualified health centers that are using that test. So that's a really good story because we see that this test consistently performs in different clinical settings. But for this FIT test, which is actually a 2-sample FIT test called Ensure, we see a very different story. So we see that there's a very high positivity rate that we see kind of across the 3 federally qualified health centers that are using that test. And we've had several discussions with the manufacturer to help us try to understand why our clinics are getting such high positivity rates. And we have gotten a couple of different ideas about why. Like one idea is that maybe patients aren't collecting it correctly. Maybe they're collecting too much stool rather than the water around the stool. And so there's a variety of potential explanations. But it's a little bit concerning if 1 in 4 of your tests are producing a positive result, and those patients will need to be referred to colonoscopy. FIT test B is HemoSure, which was the product on this table that had slightly lower sensitivity than the other ones. And what we see in our study is that they also have a pretty high positivity rate, and this last one is consult diagnostics. And so just from, I think the message here is that it's important to also evaluate the positivity rates of the FIT test that you're using, recognizing that there can be some variation, and also recognizing that the tests that really kind of perform consistently across clinical settings is probably a really good one to use. Another issue came up across our clinics with regard to FIT testing that I want to bring to people's attention in terms of making sure that you're delivering a high-quality FIT test program. So this was a site that we asked them to put together a plan for their PDSA, and they came up with this plan that really surprised us. And so they said, well, we decided to look at the number of FIT tests that patients had completed and mailed to our lab, and we had to throw them out because they weren't being completed properly. And so what we see in the bars on the left of the yellow line are the numbers of FIT tests per month that are being thrown out. And the purple part, actually the lower part of the bars are the numbers of FIT tests that are specifically being thrown out because they're missing a collection date. And so what this clinic said is that we can't send these kits on to Quest because Quest won't process them if they don't have a collection date. And so we have to throw them out, and when we can, we ask the patients to do another test, but it's a big challenge to make sure that patients are doing the test properly. And so they made some changes in their program, and what we see on the right are the numbers of FIT tests that they were throwing out after they did their PDSA. And so what did they do? Well, they changed their introduction letter to highlight the portion or the statement that encourage patients to include the collection date on the test. And this is a clinic that developed an introduction letter that was in 4 different languages. And they also developed an insert to include with the FIT test itself that visually demonstrated how a patient could put the collection date on each of the samples of the FIT test. So the message there is to make sure that all of your tests are getting sent on to the lab for processing, because each of those FIT tests is of tremendous value. And the other thing that I'll say is that, we also work with these clinics to say in integrated care systems like group health, the clinical staff will put a note in the chart saying that the patient completed this test, it was to return on this date, there was a missing collection date, but we're still going to process the test. In this case, the clinic really felt like Quest would still not be able to process a test without a collection date, and they didn't feel comfortable putting that disclaimer in their medical record. So this is another example of an improvement process. This is our work with Seymour Community Health Center, where we're testing reminders to a direct mail program because there's been a lot of interest in how do you maximize your return rate from a direct mailed approach. And so in this case, CMAR designed a study where they've identified patients who are due for colorectal cancer screening. They mailed them a FIT test, and then those patients, after 3 weeks, are randomized into one of 7 different groups. And these groups are assigned to a different set of reminders. And so the first is a postcard reminder. The next is a set of 3 text message reminders. The next is a set of 3 automated phone call reminders. There's the live call reminders, and then there's combinations of both automated and live approaches. And our goal is to look at the return rate in each one of those groups. So what we've seen so far based on preliminary data from 2 of our 4 participating sites, and this is an example parenthetically of some of the text messages that are done in English, Spanish, and Russian, and this is an example of our theory-based phone script that uses motivational interviewing approaches to encourage patients to complete their test. And so what we see is that there was about 17% of the patients completed their FIT test within that 3-week period after the mailing. And so we give patients an opportunity to complete their test before any reminders are delivered. And then the reminders boosted the screening rates by about another 10 to 15%, depending on the specific reminder combination that was used, with the combination of auto and live phone calls as well as live calls having the greatest return rate. So again, this is preliminary data. In another couple of months, we'll have some final data from patients from 4 participating clinics of the CMAR system. And what we've also looked at with these reminders is does it differ among patients who speak Spanish versus English? And so what we see in this graphic is that Spanish speakers are represented by the brighter pink bars, English speakers represented by the purple bars. And again, we see some data that's consistent with what we saw in Virginia Garcia, which is that the overall return rate is higher among Spanish speakers than it is among English speakers, which again is very encouraging because it addresses that persistent health disparity in colorectal cancer screening rates. But I think what's also interesting in this graphic is that there are specific things that seem to be, or approaches that may work better among Spanish speakers and English speakers, and that it's that combination of the automated and live approach that seems to be the winner, particularly among the Spanish speakers. So we are going to continue to look at these data, but there's some interesting things that we'll be able to sort out and help other clinics really design their programs to optimize the return rate. This is some additional data from Seymour Community Health Center, and they've mailed out about 10,000 FIT kits. Actually, this is data that's based on the mailing of about 5,000 FIT kits, and they compared that to about a similar number of FIT kits that were distributed in clinic. And what they found is that their program, which includes the mailing as well as a variety of reminders, actually had a higher return rate than clinics that were distributed, or FIT tests that were distributed in clinic. And so this is really compelling evidence that if you have a really well-designed program, that you can optimize those return rates to the point where it's even higher than what you'd find within clinic distribution. These are some of the wordless instructions that we've developed, and if people are interested in downloading some of these instructions, they can go to our Stop CRC website, which is indicated at the bottom left portion of the slide. And so in conclusion, I'd like to say that direct mail programs can improve colorectal cancer screening rates. The Stop CRC is a high-impact study, and we have very promising pilot findings. Our program was adapted using the Plan, Do, Study, Act approach, and those adaptations have been very insightful for us and can help inform future efforts to optimize screening programs that rely on FIT testing. And that future efforts might consider the reminders and using reminders to direct mail programs. Just wanted to acknowledge our funders, which are the National Institutes of Health through the Common Fund. We've also received some funding from the Kaiser Permanente Community Benefit Fund, and we work with a variety of collaborators, including here at Center for Health Research at Kaiser Permanente, Group Health, as well as OCHIN, and our 8 participating health centers. So we are happy to answer questions with the remaining 12 minutes of our hour.
Great. Thank you so much, Dr. Brooks and Dr. Coronado. That was incredibly informative, and I know I learned a lot. So I'd like to start by fielding some questions. We have until the top of the hour, so in about 12 minutes. We'll try to get through as many as possible. If you have a question, please submit it in the chat box, and we'll take them one by one. So we have already received several questions already. I'll go through them. The first one is from Rianne Clark, and she asked if there is a similar list of the Guaiac FOBTs on the market that are considered high performance. I know we touched on the one that should no longer be used, but Dr. Brooks, would you like to start with that? Do we have a list
Sure.
of the Guaiac FOBTs?
Yes, we do, and that list is Hemaculsensa. That's the list. Both the ACS work as well as the recent U.S. Preventive Services Task Force evidence review found that Sensa was the only high-sensitivity Guaiac test for which we have good performance data. There are some others that, some generic versions that have tried to slap high sensitivity on their trade name, but to this point, we've not been able to find any performance data. So if you're going to use Guaiac, you should be using Hemaculsensa.
Great, thank you. And then a question from Kristen Chestnut. She mentioned that she has heard that even though Medicare reimburses for Cologuard, that NCQA may not consider the Cologuard test as an approved test that would count towards closing a practice's gap in care for their HEDIS performance measures.
That is true at present. the NCQA largely bases their HEDIS recommendations on Preventive Services Task Force guidelines with, I guess, some attention to ACS guidelines as well. I do know that NCQA is looking at their colorectal cancer measure in light of the new guidelines that were just out a couple of weeks ago. So I would anticipate that we'll be seeing some updated, an update of that colorectal cancer measure from NCQA. Exactly what that update will consist of, obviously we don't know. But with the U.S. Preventive Services Task Force having produced new guidelines, I'm sure NCQA will look very closely at that.
Great, thank you. And then from Caleb Maring, if a patient has a positive FIT from a preventive screening, will the follow-up colonoscopy be considered diagnostic?
At present, unfortunately, yes, in most settings. Now, there are some private insurers that have already decided, and the approach that the ACS and the National Colorectal Cancer Roundtable and most of our partners have taken is that that positive FIT that requires a colonoscopy. The colonoscopy should be considered, as Gloria stated, it's part of a two-step screening process. So that's a continuation of the screening. And there are some private insurers that are have taken that approach. And Gloria, is there legislation in your part of the world, right, that addresses that?
Yeah, in Oregon, Oregon has passed some legislation that requires insurance companies to cover the follow-up colonoscopy to patients with a positive fecal test. I think Kentucky has also passed similar legislation, so we're hoping that as the states get on board that you know, that there'll be a national change as well. And
right.
I know that
there's actually work underway in Washington to try to get national legislation that would address that issue. But right now it's sort of a state-by-state or even insurer-by-insurer issue. And the same issue is also true, as I mentioned, for stool DNA testing, as well as will probably come up for CT colonography, which is also included in the new task force guidelines. So it's an area that needs attention because it's just creating barriers for people who, frankly, have been identified now as being at higher risk for having cancer. But we make it harder for them to get the colonoscopy. It's really sort of perverse.
Great, thank you. And then a question from David Gallagher. What about Colovantage or Septin9 blood testing?
That is interesting. The task force looked at Septin9, the blood test for colorectal screening. There's one test that is now been FDA approved as a blood test looking for colorectal cancer. And the task force decided that the evidence base was simply too thin to include it in their list of recommendations. There actually have been a couple of newer publications since the task force looked at it, but right now it's not included in the guidelines of any organizations. The early data demonstrated that it had close to 50% sensitivity for cancer, but polyp sensitivity was very low. Some of the more recent data indicates slightly better cancer sensitivity, but polyp sensitivity remains low. So I think that it's probably a few years from maturing. It's certainly it's an attractive idea to think about, you know, having a patient just put their arm out and get some blood drawn and they've been screened for colorectal cancer. But on the other hand, we have been burned in the past with that simple test PSA for prostate cancer. So every cancer screening test is not necessarily an advance or an advantage. So I think we're still waiting for the evidence base to mature. I don't know, Gloria, do you have any experience or thoughts on that?
No, I concur.
Okay, thank you. And then a question from Ann Lindberg. Do the FIT test results have to be read by a lab, or could a medical person read the test in a clinic?
Gloria, what's your experience?
Yeah, so there are different FIT tests, and some of them are only processed by outside labs. There are other FIT tests that can be processed in clinic, so essentially the back office tests that are similar to FOBT. So it really just varies by the test.
Yeah, in that list that I gave, there is, I think, a mix of tests. There are some that are lab processed, some that are office processed. There are some questions or concerns about the quality of the results based on whether it's a lab processed or an office processed test. And, you know, Dr. Coronado already showed you the kind of variation that you can get using the same test in different environments. So, optimally, a lab process test is likely to give you a more consistent finding, but there are some of the office process tests that may be okay as well.
Yeah, I think another distinction is whether the test is quantitative versus qualitative, and I think the basic belief is that quantitative tests are better or produce a more consistent result than the qualitative ones. So some people think that the qualitative ones are a little bit harder to read because it's based on whether the sample turns a certain color, and sometimes that can be a little subjective.
Right.
Okay, thank you. And then a question that follows that from Cheryl Sinclair: what is the average cost of having a FIT test analyzed by a lab?
Gloria?
Oh, okay. Good question. And it kind of depends on how you think about cost, but and essentially who pays. But essentially, the cost of a FIT test itself usually ranges from about $1 to $2. For those tests that get processed, so not all of them are going to get returned by patients, but the processing itself has been estimated to run about $6, and that includes both the reagents as well as staff time.
But I can tell you that some of the lab process tests in particular, I hear horror stories from different clinicians that sometimes their vendors may charge them $30 or $40 to process a single test. So there's a really wide range out there. It's difficult to talk about what the cost and charges are for different tests in the same way that it is for colonoscopy. I mean, I hear colonoscopy costs anywhere from $1,500 to $5,000. So there's a lot of variation.
Great, thank you. And then we have a question from Sherry Scheid on whether you have either of you have any experience with the BioIQ FIT program.
Yeah, really interesting question. I just learned about that program a couple of days ago because one of our Medicaid health plans is contracting with BioIQ to do a direct mail program, and BioIQ contracts with LabCorp to provide the FIT test and the processing of the test. And so BioIQ is a third-party vendor that essentially assembles mailings to patients as well as provides automated phone calling. And I don't know what their fee schedule is, but it certainly is used by a Medicaid health plan here in Oregon.
Yeah, I've had no experience with them. I've read about their program, but I think that they're relatively new to at least the Medicaid marketplace. And it's an interesting model, but I haven't seen any real data that lets me know how effective they are or will be. What I can say, and I neglected to mention with the Cologuard test, the stool DNA test, is that while it is expensive, $500 every 3 years is the Medicare reimbursement. I don't know what private insurance reimbursement will be, but that $500 also includes essentially a patient navigation component, because once the clinician writes the order for that test, the company takes over and they send out the collection kit. I also neglected to mention that because there are a small number of stool cells, of colon cells in any stool sample, the patient actually has to collect an entire bowel movement. So they send out a small kit that the patient collects the specimen in and something to mix in there as a preservative and ice packs, et cetera, to go back. But the company then takes responsibility for calling that patient and harassing them until they actually collect and return that stool specimen. So they do some of the patient navigation that has been shown to be useful in other kinds of programs.
That's helpful. Thank you. So this is obviously a very popular topic because we're at the top of the hour and we still have 5 or 6 questions. And I apologize that we didn't get to answer all of them, but we will answer them by email and send them out to all the participants in the next few days. So Gloria, would you mind passing the baton to me for the slides, please?
Oh, not at all. Hold on. There you go.
Okay, thank you so much. So I wanted to share a huge thank you to our, going too quickly through my slides, and to share a huge thank you to Dr. Brooks and Dr. Coronado for their outstanding presentations, and also a thank you to the CDC for providing the funding to make this webinar possible. So I do want to let you know we have another great webinar coming up on July 28th, in which we'll learn about colorectal cancer screening in the context of the patient-centered medical home. We hope you'll join us for that as well. And then for more information, please email me. We'll send a follow-up email to all of you with the questions, as well as the resources we've mentioned, and a link to the replay as soon as that's available in the next few days. And thank you all for joining us today. I hope everyone has a wonderful afternoon.